Good afternoon, everyone, and thank you for joining the Primary Care Innovations webinar series supported by the H. James Free Center for Primary Care Education and Innovation. Before we get started with today's presentation, a few housekeeping items. First, please mute your audio during the presentation. We'll be recording this session for future viewing, so please turn off your video unless you'd like to be a part of this presentation for a long time to come. Second, please type any questions that you have throughout the presentation into the chat function, and I'll be moderating a Q&A with the presenters at the end of the session. Finally, to claim an hour of CME credit, please make sure you complete the evaluation of the session at the end of the webinar. Today, we're thrilled to have the Healthy Kids Medical Legal Partnership team to share their presentation using lawyers to improve patient care. I'd like to briefly introduce the team who will be presenting today. First, we have Simone Chris, who's a civil rights attorney for the nonprofit Southern Legal Council and in charge of directing the organization's Transgender Rights Initiative. Chelsea Dunn, also an attorney for the Southern Legal Council and is a director of the Healthy Kids Medical Legal Partnership. Rachel Coleman is a general pediatrician and a clinical assistant professor at the University of Florida College of Medicine with a long-time interest in medical legal partnerships. And in 2018, she started the partnership as a pilot in the pediatric severe asthma clinic. Alicia Hardy is a nurse coordinator and certified asthma educator in the pediatric severe asthma clinic and is key for coordinating care for patients with complex medical and home care needs. Shrikala Prabhakaran is a board-certified pediatric pulmonologist and sleep medicine physician at the University of Florida. She's the medical director of the severe asthma program at UF and has over 10 years experience providing clinical care for children with asthma and cystic fibrosis. Thank you all for joining us and sharing your innovation today, and I will turn over the presentation to you.
Chelsea, you are muted.
Thank you, guys. I'm so sorry. You'd think I'd have Zoom, down by now, but unfortunately I do not. So today, myself and the rest of the UF SLC Healthy Kids MLP team are going to be talking to you about our project. So our three primary objectives are to help you understand how a medical legal partnership helps physicians address social determinants of health for patients. We'll also identify and describe the most common health-harming legal needs in the pediatric populations that we work with. And we also want to help you to understand how MLPs address legal barriers, leading to improved health outcomes for children who have health impairments, children with disabilities, and trans youth. Southern Legal Council, the organization that Simone and I work for, is a statewide nonprofit public interest law firm. We generally do large impact litigation, class actions, and other sorts of cases that lead to widespread policy change. But one of our big focuses is access to justice. And when we were approached by Dr. Coleman about the idea of an MLP, we really thought that it was an amazing way to impact a huge patient population here in Central Florida, North Central Florida, and also to be able to connect justice back to health was something that really interested us. So we became partners in creating this medical legal partnership. MLPs, or medical legal partnerships, are collaborations between doctors and lawyers that provide legal advice and assistance to low-income or at-risk patients and their families or support systems. The goal of an MLP is to address legal issues that are impacting family stability or social and environmental conditions in which the patients live. We began partnering with UF Health to provide essentially another resource in order to for UF Health Pediatrics to provide more holistic patient care. And our partnership was really spearheaded and advocated for by Dr. Coleman, who's the one who really got it off the ground. And so I'm going to turn it over to her to talk to you a little bit about her experiences with MLPs.
So as Chelsea said, I am a big advocate for medical legal partnerships. Quick background for me is that where I did my residency at UMass in Worcester, we had an MLP. And then when I finished residency, I took on the role of being medical director for our MLP. So I really got firsthand, hands on the ground experience with how helpful it can be in providing what I see as improved patient care. So to me, a medical legal partnership is kind of an invaluable tool in order to provide a complete medical home to my patients so they can have the health outcomes that I want for them. I think you can go to the next slide. So we'll go through basically a background. So medical legal partnership can help us as physicians better address social determinants of health that our patients are facing. So health harming legal needs can also be called social determinants of health. And what we know from research is at least 60% of our patients' health is determined by these factors. So if we're not addressing hardships in these areas for our patients, they're not going to be able to be as healthy as we want them to be. And you can see that basically all of these different categories of social determinants of health, if patients don't have good housing, if they are hungry, if they're not in a good educational setting, those things are going to work together to impact their health outcomes, and they're going to have increased mortality and morbidity. They're going to have more healthcare expenditures, and they're just not going to be as healthy as we want them to be. And what we know is that our low-income families are especially impacted in these areas. And research has shown that about 1 in 2 low-income households have an unmet legal need, and that about 70% of low-income households have had some sort of civil legal aid problem over the past year. And unfortunately, even though we do have these amazing civil legal aid organizations, for most of our patients that need that help, they just don't have good access to kind of seek out that help on their own. And so the medical legal partnership brings that into their health setting where they're more likely to be on a regular basis, especially pediatric patients, so we can help connect them to those services. And another factor, especially from a pediatric standpoint, that we think about is adverse childhood experiences. And what we know also is that if our patients have much higher stress when it comes to social determinants of health, then they have a higher chance of facing increased adverse childhood experiences. And the 3 different categories of ACEs are abuse, neglect, and household dysfunction. We have over 20 years of research now that shows us that these can have such a huge impact on our patients and increase their risk of bad outcomes. And the reason why we care about knowing what kind of ACEs our patients are facing is that we know that they can have a lasting effect in essentially every area that's been studied. And it seems to be a dose response relationship. So as you can see in the table, the higher your number of ACEs, the higher your chance of having negative health and well-being outcomes. And for us, in terms of deciding to start the pilot, what we know is that for pediatric asthma, the higher your ACE score, the higher your risk of having asthma, and the higher your chance of having difficult to manage and control asthma. So one of the things that we do as part of screening patients for our MLP is we ask the families to also complete an ACE screener, so that we can know what their level of stress is in that area, and that we can make sure that while we're addressing those health harming legal needs, we're also helping to address any trauma that these kids have been facing. Because if we know about it and we can address it, then we can help promote resilience for those kids and improved outcomes down the road. And we also know, in terms of we'll get to in the future, some of the areas where we've been trying to expand our MLP, ACEs and social determinants of health also have a big impact in other medical problems, specifically diabetes and sickle cell disease, which we'll talk more about. So what can lawyers do about all these problems that our patients are facing? You know, the short answer is they can do so much. And as a pediatrician, I now, you know, because I know this tool is out there and I know how incredibly helpful it can be, if I don't have it accessible to me, I feel like I'm not providing the best care I can to my patients. And so this is just a little helpful different categories that lawyers can help address for us. So income can be things like food stamps that have been denied, or cash benefits or disability. They can help us with addressing problems there. And housing, you know, if patients are living in poor housing, lawyers can help us address problems in those areas. Education from a pediatric standpoint is huge. So many of our patients are unfortunately facing barriers with accessing the services they need in education, and our attorney partners can help us with that. Legal status, they can help with getting stable legal status, which can help with access to employment. And then when it comes to stability, that can be things like adoption, custody, guardianship. And we'll talk more about all these categories down the future. But I mean, it's really is an invaluable tool to us as physicians. You want me to do this, Chelsea, or are you tackling this?
Yeah, I got it.
Okay.
So our Healthy Kids MLP first launched in November 2018. We started with a pilot program in the Severe Asthma Clinic. We, as Southern Legal Counsel, my firm, began sending attorneys, myself and other attorneys in my office, on site to the Severe Asthma Clinic one day a week. Fridays is when the clinic's held. And we would offer patients at the Severe Asthma Clinic legal screenings, meet with them, talk about different issues they were having that were impacting patient health, or just other social and environmental factors that were increasing family stress, in order to try to provide some sort of legal intervention or legal advice and support. The Severe Asthma Clinic we focused on because we knew that it had high rates of patients who are on Medicaid. A substantial portion of its patient population is minority or low socioeconomic status, and asthma is a health condition that is particularly vulnerable to poor social and environmental conditions. And so we thought it's somewhere that we could make some change. And now I'm going to pass it over to Alicia to talk a little bit about the Severe Asthma Clinic and what it is.
Hello, everyone. So yes, what is Severe Asthma Clinic at the University of Florida? It is comprised of a team of like-minded health professionals. Our doctor is Dr. Shrikala Prabhakaran. She's our director. We have a nurse practitioner, Don Baker. We have a clinical pharmacist who's now retired, but he is an emeritus, and he visits our clinic about once a month or so. And then, of course, myself, I'm the nurse coordinator for the clinic. We do hold it every Friday morning, depending on schedules and things. And it was started in 2016. Basically, our goal and our mission is to identify, coordinate, and then implement care for patients with high risk and life-threatening asthma. Also, we provide detailed asthma education. We individualize their asthma action plans, and we review inhaler technique, and we do this every single time they show up in our clinic. And we also have what we call, quote, special resources. And that is, we solicit the help of school nurses. And I'll talk about that more in a moment. But then also, we just recently started a partnership with our pediatric allergy team. And so they are another branch of service that we offer. We do specialized diagnostics, like a pulmonary function test is unique in that it gives us the information about the airway inflammation or obstruction. But we also, because of pediatric patients that cannot do appropriate technique for PFTs, we offer IOS, impulse oximetry, that can show us airway resistance, as well as ENO, exhaled nitric oxide. It can give us a number to let us know the degree of their eosinophilic inflammation. And then last but not least, and the focus point of our presentation today is that we have the medical legal partnership. Next slide. So I want to just expound a little bit on our special resources. This is just a snapshot of a publication to show the work that we do as far as partnering with the school nurses. We establish a relationship so that when we identify patients that do not have good med adherence, the school nurse in Alachua County and other counties will give their controller medicines while they're at school. So at the very beginning of the school day and the very end of their school day. And so this publication just shows, it was the outcome that shows there was increase in their pulmonary function and decrease in the number of exacerbations, hospitalizations, ER visits that patients experienced. I'll pass it on to Dr. Dr. Prabhakaran now.
Hello, everybody. Good afternoon. As Alicia said, we have the severe asthma program since 2016. As you all know, asthma is a chronic inflammatory disease, and most of you guys manage that as in our clinic. And as you see in the picture, the patients feel their airway is on fire because of the inflammation. And this inflammation causes mucus hypersecretion, bronchoconstriction, and this causes the symptoms of breathing difficulties, of cough, shortness of breath, chest tightness, when a genetically predisposed person come in contact with an allergen. As I said, there is genetic predisposition, and this runs in families. That's why we all just talk about the asthma predictive index. And it's more prevalent and more severe in low socioeconomic status. Next. And why asthma is so important? It's very common, right? It's 20 million people in the US and 300 million people worldwide are affected by asthma. Out of this number of people, 5 to 10% of them only have severe asthma. And severe asthma is not completely a different phenotype. But this patient population requires a lot of medical resources to keep their asthma under control. Global Initiative for Asthma and NHLBI classify asthma into several different categories, depending on the severity and frequency of symptoms. And there is a stepwise approach to treat asthma, depending upon the severity. The diagnosis of severe asthma comes when they require GINA guideline 4 to 5 for asthma treatment, but still their asthma is not very well controlled. And you know that asthma is a very expensive disease. Last year itself, there was $28 billion in America spent for asthma. In our severe asthma program, not all the patients are severe asthmatics, but they are difficult to control asthma. And that's why we do need to be a bit creative and think out of the box resources like school asthma education, and now the new baby in the block, medico-legal partnership. Thank you, Rachel and Chelsea. And now Chelsea will talk about the lawyers, how the lawyers can be our friends. Thank you.
Thanks, Dr. Prabhakaran. As you guys, I think, heard, the Severe Asthma Clinic was already taking such a collaborative approach and kind of reaching out into the social environmental factors that were impacting their patients. So when they heard about us, they welcomed us as part of their team, and it's just been so wonderful. We are right there in the room with them on clinic days, talking about patients, figuring out how to address some of these issues, and it's such a wonderful partnership to have. So how do we help their patients? One of the primary issues that we address is education. And this actually turns out, we didn't know this would be such a big need, but it's a really good fit because Southern Legal Counsel, our firm, has a long history of helping children with special education needs or needing other sorts of accommodations in school to address issues, and so that they can be in as mainstream of a classroom as possible. So one of the things that we help to do is help parents understand what their children's rights are at school. When children have health impairments or diagnoses such as asthma or ADHD, we make sure that they're receiving the accommodations that federal law entitles them to, either through a 504 plan or an individualized education plan. The difference between those two is subtle. An IEP generally is services that are being provided so that a child is able to meaningfully access the curriculum being provided at school, whereas a 504 plan is more about accommodations that give a child access to the classroom. So you could think of a wheelchair ramp versus, which would be provided in a 504, versus occupational therapy or speech therapy, which might be provided in an IEP. Oftentimes, kids who are attending the severe asthma clinic or some of the other pediatric specialty clinics are missing a lot of school days because they have to for appointments. And that shouldn't be held against them. That is an accommodation that can be addressed under a 504, giving that child time to make up their schoolwork, making sure that the absences aren't being counted against them. One of the things Dr. Coleman talked about earlier was trauma and the importance of trauma in helping families in a trauma-informed way, the importance of ACEs, of knowing ACEs. A lot of the kids that we're working with from families of low socioeconomic status or minority backgrounds have experienced some sort of childhood trauma. And trauma is something that can trigger the need for an individualized education plan, an IEP, or a 504. It is considered a health impairment if it's impacting the child's ability to maintain at school. So we might see kids who are having behavioral issues, who are frequently being referred for discipline. And if they have a high ACEs score, that's gonna let us know that there might be a history of trauma that might necessitate a letter from a doctor so that accommodations can be implemented at school to address that trauma so that the child can remain in the classroom and benefit from the education. We've assisted families where there are multiple caregivers and someone needs to step in and be the primary educational decision maker, helping them understand how to navigate that process. And most recently, we've been helping address COVID-related school issues, specifically kind of the access to education issues that are presented when kids are doing distance learning, but they're on IEPs and they normally are receiving special services, and how that's looking in a virtual world. So we are going to talk about some case examples for each of these legal issues. And Dr. Prabhakaran is going to tell you a little bit about Bobby, who was a patient client of the MLP.
Yeah, just like, the COVID has been having a lot of trouble for our patients, severe asthma patient population, and parents have always concerns. They can send the patient home to school or just doing online schooling. And some of the counties are insisting on the in-person schooling. This is exactly an example here. Bobby is an 8-year-old boy who was born 24-week premature baby with very complicated history. And he was intubated and on mechanical ventilation for several weeks in the hospital, and actually 3 months in the hospital. And you know that being born at 24-week, he has chronic lung disease of prematurity. He had pulmonary hypertension. On top of that, he has significant family history of asthma, and he got asthma too. So with significant airway obstruction, with being born at 24 weeks, he is having a lot of exercise intolerance, and he's requiring a lot of systemic steroids and asthma medications. And he is having ADHD and learning disabilities also. That is, the mom was really struggling how he can get the IEP and then help in the school. And mom talked to the school, not much help. We gave letter, not much help. That is when the big lawyer comes into play. Chelsea, how did you help this kid?
So when we met with Bobby's mom, she explained to us that, so he was an 8-year-old ESE. ESE is what we call special education here in Florida. It stands for Exceptional Student Education. He was on an IEP for what's referred to as an other health impairment, which is kind of a catch-all whenever a student has maybe a behavioral health diagnosis, ADHD, or any variety of health issues that might lead to a difficulty in accessing school. Right after COVID began, so the end of the spring semester, his mother moved him from Alachua County to Levy County School District because it was a little bit easier for her to get him to and from school because they actually lived in Levy County. When he moved to Levy County, they changed a bunch of things on his IEP without really any explanation. And his mother didn't really understand what had happened. But when I talked to her, what she did know is that he wasn't receiving the same one-on-one services and occupational therapy services that he had been in Alachua County, and he was really struggling in virtual education. When we started looking into the case, we also realized that he was 8 years old. And by law, a school is supposed to evaluate a child every 3 years. He hadn't been evaluated since age 3, which is well over the time limit. And I'm sure, you know, as pediatricians, you know how much changes for a kid from between the age of 3 and the age of 8, developmentally and, you know, just in terms of their functioning. And so he was also in need of new evaluations to determine whether or not, you know, additional services were necessary or just kind of where he was in his educational progress. So we requested an IEP meeting on Mom's behalf, and we attended with her. And, you know, this wasn't a huge fight. In fact, the school was really responsive, which unfortunately is often the case. Parents frequently are unable to get the same level of services, the same responses when they're self-advocating as when they bring an attorney or advocate into the room, which is unfortunate. But in this case, you know, we ended up with all the things that Bobby needed. So his IEP was changed. When Levy County implemented the IEP, they placed him in a self-contained special education classroom, which he didn't really need. He didn't have that level of need. And the IDEA, which is the federal law that governs special education, requires students to be in the most mainstream classroom possible, the least restrictive environment. And he was not being placed in that environment. So we got him back into an inclusive mainstream classroom. We got him set up with a one-on-one aide who would meet with him individually after the teacher in his classroom provided instruction, and we got the consent signed so that the school could begin evaluations. We also got his occupational therapy resumed, so we started receiving that on a weekly basis. This not only did, you know, we enable Bobby to get the services he needed to access his education, but we also decreased the family stress. Mom had actually left her job because she was finding it so difficult to help him through the virtual learning. And so once he started getting the one-on-one assistance he needed, that decreased the need for her to be teaching him. And so she is now able to return to work. The MLP, so in addition to education, housing is a big issue we see. So we see environmental factors such as mold, you know, other poor housing conditions, broken heat and electricity that are impacting patient health, exacerbating allergies, exacerbating asthma. Attorneys can help address this by sending demand letters to landlords. We can advise clients. There are certain situations where families, leaseholders, are able to stop paying rent because the house that they're living in is in such poor condition. And we can explain to them what that process is and how to participate in it and withhold rent in a legal way so that they don't get evicted and so that it forces the landlord to make the necessary repairs. Not necessarily housing, but certainly related to environmental stability. We can help families identify where they can get food or sign up for food stamps. We can help make sure that if they're having trouble paying for their utilities, which here in this area is a huge problem. I know GRU is considered to be very expensive. There are programs that assist families so that they don't lose electricity and they can continue having heat, hot water, and other things necessary to make a living environment habitable. And so we can help, connect them with programs like that. So Alicia's going to tell you a little bit about our experience with Rosie S.
Okay, so this young lady came to us, 10-year-old girl with poorly controlled severe persistent asthma. We qualified her as severe asthma because of her utilization of healthcare services. Her family had even had to call 911 from home for her to be transported by ambulance to her hospital. She has a history of 3 pediatric intensive care unit admissions. Her history also includes eczema and allergies. And when we first started seeing her, her IgE was greater than 6,000. She is seen by multiple disciplines for morbid obesity. She's pre-diabetic, and then she also has a history of partial seizures. Some of the barriers to getting her asthma under good control for us was one of the most prevalent, and that's medication adherence. But also she had a difficult social situation and living conditions. They had difficulty acquiring transportation to and from clinics. And then the patient had developmental delay. So some of the things that Severe Asthma Clinic was able to offer and help her get in a good place with asthma control was that we were able to assess her by using the impulse oximetry. We also stepped up her asthma treatment from just an ICS alone to ICS LABA combination drug, Advair. And then we really took time to give dedicated asthma control and devoted time for compassion in this case. Because of the situation, the social situation, there would be instances where I would actually clean her aero chamber in clinic. There were times that we would smell body odor. There would be insects coming from some of their belongings. So just providing non-judgmental, compassionate care. We did solicit the help of our school nurses to give her asthma controller therapy. And then we, of course, introduced her to MLP.
So when we met Rosie, I think at the time she was 10, she's now 11, they were living in uninhabitable conditions. Their home had never been repaired from Hurricane Irma. They didn't have running water, and there were issues with electricity where they were using extension cords to bring electricity from one part of the home to the other. We worked with the family, helped them understand that because of the condition of the property, they were able to withhold rent, gave them the paperwork to send to their landlord. However, the landlord never made the repairs. And so they used the money that they weren't paying in rent to save up to obtain alternate housing. Unfortunately, what we didn't know at the time is that new housing wasn't necessarily ideal either. Because of grandmother's credit issues, the new housing they got, it was a mobile home in a mobile home park, but it wasn't owned by the mobile home park. It was owned by a third party, and it was falling into disrepair. So we got called back onto the case when codes enforcement sought to condemn that mobile home. So we worked with code enforcement and the mobile home park they were living in, and of course, Rosie's grandmother and the leaseholder, to delay the condemnation long enough so that the family could gather their belongings and so that we could seek alternate housing. And the mobile home park was able to offer them another unit in much better condition that they were able to move into within a couple weeks. In fact, I think it might have even been a couple days. So they were able to resolve that issue without having to experience homelessness, which, for any family, that is a traumatic situation and something we want to avoid. And ultimately getting Rosie and her family into better conditions was the goal that we were able to achieve. We've also assisted clients with medical benefits. So if a patient's family or a patient is being denied Medicaid or kid care, if they're entitled to it, whether it be an overall termination of the coverage entirely, or whether it's just that a service is rejected, we're able to help the family appeal that. We've also helped families who are having transportation issues. Medicaid transportation is, I'm sure you all are aware, less than ideal, but for families who have no other choice, it's a service they can access. The other thing we've helped a lot of patient families with is that if they can find their own transportation, they can get reimbursed for it through Medicaid. So that helps families who might have a friend or a family member who are willing to drive, but they want to be reimbursed. They can access more reliable transportation and reimburse that person for their assistance. And I'll turn it over to Dr. Coleman to talk about our shared patient-client, Daisy.
So this is a patient of mine who I believe is now 16, but this was a year or two ago. She has a pretty complex medical history, including autism, ADHD, PTSD, and ODD. So dad had been working hard to try to get her in with various specialists, and including trying to get a new neuropsych evaluation because of some difficulties she was having in school that we felt like we weren't quite addressing her needs. And, I would put these referrals in, and then I would notice that they weren't getting scheduled for the appointments, or they would end up canceling the appointments. So when they came in for a follow-up, I tried to kind of dive in a little bit deeper with the dad to figure out what was going on. And he let me know that he was continuing to have issues with her insurance not being stable, that they would tell him 1 month that he could have this insurance, and then the next month they would kick him off of it and tell him that he made too much money. And he was saying that all along his income had been stable, so he wasn't understanding why he was having so much difficulty. And kind of my process now that I have the MLP, whenever patients have things like that just don't make sense to me and don't seem like things are happening the way that they should, I reach out to Chelsea and I say, can you help, please? And in this case, she helped in an amazing way.
So we worked with Daisy's dad, figured out that obviously if he had the same income, there was no reason she kept getting terminated. So we filed a complaint on his behalf. with Medicaid Kid Care, or we actually filed it through AHCA, which is Agency for Healthcare Administration, which is the agency in Florida that oversees all of the Medicaid programs. So we filed a complaint with them about these terminations with all the documentation of the letters he was getting. And within a week, it was resolved. All it took was someone in AHCA looking at this and talking to Kid Care and saying this, what's happening, and it got totally resolved. He stopped getting termination letters. And we were able to resolve the problem in time for Daisy to go to that neuropsych appointment. She'd been on a wait list, waiting for an appointment. They'd had to cancel earlier appointments, and then she'd been waiting for another one. And she made that appointment and got that evaluation. It started us on a process of helping him use the information from that evaluation to get her the right supports in school, which we worked with him on that as well, but that's an aside. We also can help families who are having either custody issues or there are issues with child support. Anytime that a family is in need of additional income, we can help problem solve, and helping a family file for child support or file a change in child support is something that we can and have done. Where domestic violence might be impacting stability of the family, housing stability, it might be creating trauma to the kids, we can help families file for protective order assistance with the courts. We've also helped, for stability, for job stability, essentially, I think, which can be very important when a family actually does have a job, they don't want to lose it. Taking a child to many doctor's appointments can sometimes put you at risk of losing your job, but as long as the employer is covered by FMLA, it shouldn't. And so the FMLA medical leave, it doesn't have to be one big chunk. You can take off intermittent days in order to take a family member to doctor's appointments. And so we've helped make sure that parents of severe asthma clinic patients have the appropriate paperwork to file, and followed up with employers when there have been issues. And we also have helped many families apply for SSI benefits, because overall, if a family can have additional income, it provides more security and it helps the family focus on addressing the health impairment instead of just basic survival. So that's also something that we often seek to do. And I'll turn it over to Alicia to talk about our shared client patient, Hugo.
So this gentleman, 7-year-old boy, again with poorly controlled, severe, persistent asthma, he had frequent exacerbations. Almost every time we would see him in a follow-up visit, he was sick with coughing, wheezing, chest tightness, poor PFT result, and required multiple courses of steroids. So his history is not very substantial, but he does have ADHD and chronic allergic rhinitis. So some of the barriers to getting him under good asthma control was, again, medication adherence. And then he had a difficult social situation. So in a severe asthma clinic, when it comes to the education we provide, we want to make sure that all caregivers taking care of Hugo understood what his asthma was, how to treat it, had an action plan. But he would come to clinic with different caregivers depending on dad's girlfriend or aunt, whoever was available, because dad had a strenuous work schedule. And so that was one of the barriers for the most part. And there was DCF even involved in his case. So our actions was, of course, we used the iOS again for young age patients for us to be able to assess his lung function. We give asthma education. We stepped up his asthma control therapy, but just the difficulty with the caregivers and the living situation, we handed off to MLP to help.
So when we got involved, the severe asthma clinic team told us, one of their primary concerns was that when Hugo was with mom, it seemed like his asthma was going totally, unmedicated and got out of control. And so we talked with dad to try to investigate what was going on with the parental responsibility arrangement or the custody arrangement. And dad told us that Hugo's mother had been investigated by DCF in the past. And as a result of that, Hugo got placed with him, but he was not on the birth certificate and no one had ever taken the steps to help him establish paternity. So he couldn't have custody of Hugo because he didn't even have paternity of Hugo. And there were times when he would bring him down for a visit with his mother, and his mother would refuse to return him. And this was a huge problem because dad didn't always bring the asthma medications because he didn't want them to get misplaced when Hugo was with mom. So we started helping Dad, and it's not been a short process. The first barrier to tackle was to helping him get paternity. He and the mother had an ongoing child support case about Hugo and Hugo's sister. And so in one of those court proceedings, Dad took the steps necessary to establish paternity. And so he legally became Hugo's father, which gives him the rights to obtain custody of Hugo. And for a while, that seemed to address things just fine. But recently, Hugo's mother again held him over for a day visit. He didn't have his medications. Hugo's dad called us, not sure what to do. So immediately we worked with Dad to figure out a plan where his medications could be dropped off with grandparents. And we helped him prepare the paperwork to file in court to get a pickup order, which is an order from the court that allows one parent to pick up a child from the other. And now Hugo's been placed back home with Dad, again with DCF getting involved. He has a court date scheduled for a custody change, so they're working through that, and we're helping him provide, complete the paperwork to get a supervised parenting plan in place so that he has full parental responsibility, and then mother's visits are being appropriately supervised so this doesn't happen in the future. And
so these are the total numbers since November 2018, and what we've seen is a total of 114 legal issues identified. And this, Chelsea, is this just severe asthma, or is this every patient?
All the cases we've done, severe asthma and other referrals that we've gotten.
And as you can see, definitely the most common issues that we end up identifying in our patients are education related. There's also been a good number of housing issues, income maintenance issues. Family law has been another common problem to address for patients. And so as you can see, it's been a wide variety overall. And I think the other thing is that this is, a half day in severe asthma clinic. Most of these patients, some of them are from other areas. And then also there was a big, probably about 6 months with COVID where Southern Legal wasn't able to be in clinic and we weren't screening patients the same. So these numbers would be significantly higher if we weren't in that situation. So I think, it's clear that our patients are facing lots of need when it comes to legal problems, and that Southern Legal can help us address those in a big way.
And what those numbers don't totally tell us is one thing that we think we're doing pretty well, which is helping to address racial disparities in the types of problems that the patient population is experiencing. So this is in part because of the clinics that we're collaborating in, which like the severe asthma clinic, some of the other clinics we've expanded into also have majority minority populations. From a broader perspective, when you look at the civil legal aid system, racial minorities are more, just like in other areas, just like in criminal justice and other areas, racial minorities are disproportionately impacted by problems within this system. Overall, there's a civil legal needs crisis in America. So the types of cases we're talking about, those are cases that most people in America are forced to go into court unrepresented. And that's because unlike most industrialized nations, we don't have a right to counsel in civil cases, only in criminal cases. Even the funding we do have for legal aid services is really deficient, and most people who go to a legal aid to have a case taken are on long wait lists. And data from various studies and state, analysis of state court numbers show that racial minorities are disproportionately impacted by the civil justice system, that they tend to be involved in these cases more, and they're less likely to be represented in court. Similarly, they have higher infant mortality rates, higher ACEs, shorter life expectancy. So, we're just seeing negative outcomes in so many places. And the numbers that we're seeing in the MLP, demonstrate that. So 63% of the legal issues that we've identified are experienced by Black or Hispanic families. Just like these other forums, minority kids are having a harder time in school and having overall worse educational outcomes, more likely to be arrested at school, and more likely to either be physically restrained or isolated while in school due to a discipline problem. And, again, we see similar breakdowns in our education cases. So 66% of the education issues we've identified have been experienced by Black students. And some of the issues that I think are most telling of what the problem is that often when it comes to Black students, there can be a failure to identify and evaluate for special education services because the narrative of the school is that this child is a problem child. And so behavioral and mental health diagnoses that in a white student might be identified and addressed through an IEP are just being treated as problem behavior or as a discipline issue. And so that's one of the things when we're advocating for our patient clients at school, we're making sure that the schools aren't doing these or taking these actions that are pushing minority students out of school. Our Healthy Kids MLP has had its challenges. The primary, I would say, overall has been our lack of funding. So our Southern Legal Counsel has a grant that does give us funding for our educational cases, but the other legal issues are addressed as we find capacity, and we have a pro bono program that recruits attorneys who volunteer their time. But this does limit our ability to reach the entire pediatric population. The most successful and longest lasting MLPs tend to be funded by the health institutions that they collaborate with. And being a part of the health institution also breaks down some of the barriers when it comes to information sharing that HIPAA provides. And so having institutional funding really can benefit an MLP. The other barrier, which Dr. Coleman just mentioned, is that COVID has had a huge impact on our intake. We haven't been able to be in clinic. The Zoom clinic that was being held, I have to say, the clinics at UF were so resourceful. And I know that patients were being given appointments by Zoom, which was a whole new world, but it seemed to be going really well, except for MLP, where we weren't having, we couldn't actually be in the same Zoom room as the patient appointment for privacy reasons. And we weren't having, there was the ability for patients to click through to enter our Zoom room and meet with us. And there just wasn't really much patient follow through on that. The last barrier, which we're hoping will be addressed, is that we have a pretty cumbersome referral process that requires providers to print off forms, fill them out, have parents sign them, and then fax or email them to us. We're working through trying to get a referral set up on Epic, but it's been a work in progress for some time now. And so there's still huge barriers to kind of having a seamless intake process. The good news is, though, that we have been expanding. So we, as we mentioned earlier, we've expanded. We're taking referrals from other places. So we have started taking referrals from pediatric endocrinology, specifically the diabetes clinic. And we've trained the providers in the pediatric hematology oncology unit to send us referrals as well, specifically focusing on the sickle cell clinic, the diabetes and sickle cell clinic. I'm sure you guys know have similar patient populations, low socioeconomic status, lots of patients on Medicaid, and majority minority population. So it's kind of the same area, the same level of needs. And so we're seeing what we can do to try to help a broader group of patients. Our last expansion has been that we recently began having an attorney embedded into the Youth Gender Clinic. And this is Simone Christ, who's the director of our Trans Rights Initiative at SLC. And I will turn it over to her to tell you what she's doing with that clinic.
Hi, like Chelsea said, my name is Simone Christ. I'm the director of our Transgender Rights Initiative at Southern Legal Counsel. And I have been fortunate enough to be able to work with the Youth Gender Clinic, which is within the Department of Pediatrics and the Division of Endocrinology, and it provides medical care to transgender and gender nonconforming youth and their families. Most of you probably know this, but transgender and gender nonconforming youth and individuals are those whose sex assigned at birth does not match their gender identity or gender expression. So your gender identity is the gender that you identify with, and no one knows what that is except you. And some people are born with the sex they're assigned at birth ends up not matching their gender identity, and they identify as transgender. And there is a huge gap in access to care for this population. I know that the program began in 2016 when Dr. Janet Silverstein, was one of the, I think, leading people in the country to really identify that this is a patient population that is so underserved, both in the medical realm and in the legal realm. So it's kind of incredible that we're able to bridge the gap in access to medical care and the gap in access to justice within this clinic. So youth gender clinics are critical for many reasons. One is, like I said, there's such a disparity in health outcomes for trans individuals. There are so few medical providers that are really trained in how to meet the medical needs and healthcare needs of the LGBTQ population in general, but specifically with regard to trans individuals and with regard to trans children. There's not a lot of knowledge out there. Medical students in school aren't taught about this population and how to meet their unique needs. And so just to give you a quick rundown of why it's so important, a third of trans individuals have had negative experiences while trying to seek healthcare from providers, including having to educate their own doctor on what it means for them to have a transgender identity and what their medical needs are. Over a quarter have avoided seeing a doctor or seeking medical attention that they needed because of the fear of mistreatment when accessing healthcare. 40% of trans individuals attempt suicide in their lifetime. This is a staggering statistic. This is 9 times the national average. So when it comes to access to mental health care, this is a huge need among this population. And with regard to youth, nearly 40% of our country's homeless youth identify as LGBTQ. So there's just so many unmet needs within this community. And I'm so grateful that this clinic exists to meet those needs. I have clients, I'm a trans rights attorney basically, and I have clients from around the state that travel to see the doctors in this clinic, to get their care from this clinic, because many folks in rural areas just simply don't have access to a doctor that's affirming and understands their needs. So what do we do? The biggest issue that I've found in screening these youth is education issues. So in general, over 2/3 of trans youth experience mistreatment at school, whether it's verbal harassment, physical attack, sexual assault, or just being denied access to the bathroom. Such a simple thing as having to use the bathroom when you're at school all day. I have so many clients that don't drink water, that don't eat, that try to avoid natural bodily functions because of the fact that they don't have a bathroom that they can use that matches their gender identity. So education issues are a huge thing. The next biggest issue is access to accurate identification, which most people don't even know that what is required to obtain a legal name change. There's all these forms you have to fill out. You have to have a court hearing. There's a $400 filing fee. And as most of us know who work with diverse populations, oftentimes just the filing fee alone is enough for them to think that they're precluded from obtaining a legal name change. And imagine going around in your day-to-day life with a driver's license or identification document or school badge that says the wrong name, that says the wrong pronouns, the wrong gender marker, that has a picture that doesn't reflect who you are. It's incredibly stigmatizing. And so I help folks with legal name changes and gender marker changes. And oftentimes this requires another aspect of legal assistance, which is custody and guardianship issues, because youth unfortunately cannot obtain a legal name change or gender marker change and update their documents to reflect their gender identity without having an affirming, supportive parent that's willing to do that process on their behalf. So oftentimes the first step is helping mom or dad or grandma or whoever it is determine, figure out how to get legal custody or figure out how to obtain the legal name change and such for their child, even if they have another parent that's not supportive and affirming. And a huge thing is making sure these folks are aware of filing fee waivers so that financial burdens aren't a barrier. So just to give you a couple examples real quick of cases that we've helped with. The first example is a high school senior, a trans 17-year-old girl who I helped. She had not had access to any type of legal transition. And she's 17, she's trying to get a job and she has a driver's license that says she's a boy and she's not. It has this name that is her dead name. She hasn't used in years. So helped her update her name and gender marker on everything, including, most importantly, her school records. And to update your school records, you have to first update your birth certificate. And so she had been, the whole name change thing was huge for her, but she had been pushed out of school in Marion County, really rural school, rural county, had been pushed out due to bullying, and there were no teachers that were protecting her or intervening in this. So I worked with the school. She was taking all online classes as a result of being pushed out of school. Chelsea, you can go to the next bullet point, sorry. So anyway, I was actually able to, through this one case, educate the entire school district on the fact that transgender youth who have a diagnosis of gender dysphoria, sometimes the depression, psychological distress, anxiety, et cetera, that comes from having gender dysphoria and being transgender can rise to the clinically significant level of making them eligible for an IEP or a 504 plan. So I was able to educate the district on, that these students sometimes might need additional supports and accommodations through special education services. And we were able to get her the supports and accommodations she needed, and to get the school district to appoint an LGBTQ liaison, student liaison, to help students like her who've been pushed out of school or who are experiencing bullying to have a safe support person at school. So that was a district-wide change. And she is now doing great. I got her a fee waiver so that she could take the ACT and SAT, which were a requirement to graduate. Mom didn't have the money for that. All right, next example. Sorry, I know I'm running out of time. Another one was a student who was being denied access to the bathrooms. He was literally required to walk all the way across the school to this random portable where they had like a non-female or male, non-gendered bathroom that was really just an old like staff bathroom. So stigmatizing for him. He would have to choose to miss the first 10 minutes of class or hold it all day and not go to the bathroom. So he was falling behind because of how difficult it was to just physically be present at school. So we were able to get the school to allow him access to the boys' bathroom, to update his name and gender marker in the student information system so that he wasn't outed every single morning when the teacher called roll. And also to get them to take a look at their policies and practices that at the time did not protect LGBTQ youth. And they were actually willing to revise their policies to allow access to bathrooms for trans youth and other such things that impacted not only this child, but other kids in that district that were probably experiencing the same type of discrimination. So that's just kind of a quick overview of the issues we're seeing in the youth gender clinic.
So just quickly, our next steps are hoping to have a referral and screening via Epic. We're working on advocacy template letters that will be available to providers where you can give your client or your patients a letter to obtain accommodations at school, in housing, or something like that. We're also working to apply for IRB approval so that we can assess our impact and also survey the MLP's impact on clinicians' knowledge. And next is questions, which I know we have almost zero time, and I apologize that we ran over, but thank you all for spending time with us today.
No, thank you for presenting. I mean, really just a phenomenal program. I think all very inspired, and just thinking about ways in our own practices that we can begin to work in this manner. For those that need to sign off, thank you for joining. Don't forget your CME. I did want to, for those that can stick on, just a few questions that came up. It looked like some of the template may get to this, but there was a question in terms of, for providers, are there, places where we could find resources? It sounds like, in many of these cases, it was, appropriate letter or kind of having the knowledge to know that something wasn't right, as kind of Dr. Coleman spoke to. Are there resources that we, that may not have this partnership established could reach for to help address some of these issues outside of a partnership like this?
Yeah, we do have some self-help resources for families and providers, just with basic information, which we've made available to the divisions we've collaborated with. But I think we can make that more generally available. It's just figuring out how, like where will those forms be hosted, and the advocacy letters will be available via Epic when we can get that resolved. So one of the barriers to the fact that we are not actually housed in UF, the MLP technically, you know, with SLC, we're separate, is that we don't actually have access to Epic. And so we can't work with the Epic team to get forms up there. So we've, you know, we're working on it, but there's kind of a barrier there. So we hope in 2021 to make all of that much more widely available.
And there are like screening tools that are available. So if people want something that's just sort of a list of questions that you can ask families to try to get at things, you know, that does exist. I think if the rate limiting thing then is finding the person to help you with it once you identify. And I think there's definitely, I mean, we are working on doing more education to different departments. So if people are ever wanting more in detail, then we can work on that. But a lot of it is the more you screen for it and identify, the more you learn how you can make an impact. And I would argue then we could all as physicians advocate for more medical legal partnerships.
Yeah, absolutely. I think I know you all addressed this, some was just in terms of funding. So has this program been primarily grant funded? Do you have donors or other people that support your work? Because it's certainly very valuable.
So currently just grant funded. You know, when I worked to get it started, I had like 10% funding through the Children's Miracle Network that helped with making the connections and kind of getting things going. And we hope to, that's another thing that we talk about regularly, is trying to seek out, you know, donor partners in the community to see if we could get additional funding.
And SLC, you know, we devote our attorney time, which is paid for by grants or by donations that we receive from individuals. So, you know, that's kind of how we've managed to put together the funding to be here.
Yeah. Another question was about, you know, a common problem we see is medications not being covered by insurance carriers. Have you all had experience from a legal perspective helping get coverage for certain medications?
We have not specifically handled that case, but I would encourage anyone who's experiencing that to at least, you know, consult with us. You know, the Medicaid coverage, so it depends on the insurance carrier, but Medicaid should cover anything that's medically necessary for a child. There's special provisions that relate to Medicaid coverage of children. And so, you know, that's not a fight we've had with an insurance company, but it's certainly one that we could. And actually, Simone may have worked with insurance companies to get certain types of hormone medications provided. So
yeah, when it comes to not just youth, but any trans person, oftentimes there's exclusions for gender affirming care. And we have a current federal lawsuit on that. So I definitely am happy to consult with anyone who has questions about getting healthcare providers to cover, whether it's, you know, inhalers or anything like that, or gender affirming treatments that excluding them is sex discrimination. So definitely consult with us, and we're happy to help with that.
Thank you so much. Thanks to all the presenters, and really, I think, eye-opening and really incredible work. Thank you all for sharing today. For those that were part, if there's folks that you know wanted to see the presentation, it'll be on the Free Center website within the next day or so, so it can be shared. And then for those that joined, please evaluate and give our speakers some feedback on the presentation to be able to receive CME credit. Stay safe, have a wonderful weekend, and happy holidays. Thanks so much.
thank you.
Everybody.
Bye.
Bye.